Just give everybody another couple of minutes or so. I think we're nearly ready to rock and roll, which is another subject close to my heart, as well as Preston North End. But we'll just wait a couple more minutes. I can see Ginny's joined us. I can see Ginny for the first time. Hello, Ginny. Oh, and Martine. There's Martine. Hello. And I can see Nick. I can see Dean. Who else can I see? Jackie. I can see Andrew. I can see Erin, Emma. I can't see London. I'm desperate to see London. Really, I'm desperate to see London at some point. Oh, there's Nick. Hello, Nick. Nick's there, showing everybody. Oh, I've got South Central then, Nick as well. Brilliant, brilliant, brilliant. Hi, we'll unmute. Hi, West Midlands. Andy's here as well. We'll unmute everybody in a moment.
I've just realised that the camera's on, and I've just been looking like a complete lemon trying to figure out.
I've spent the last 2 days looking at a screen, looking like a lemon, Ollie. I won't worry about that, mate.
Just think after today, sleep, food, rest,
absolutely, absolutely, absolutely.
And repeat, and repeat, and repeat.
When do projects B and C start, Ian? Because we're quite keen to get involved with that.
I think they might be finding a new programme lead for B and C, Ollie, because I'm shattered, mate. Right, I'm going to give people 1 more minute, and then I'm going to do a quick roll call to see who we've got. So we'll probably unmute you all at that stage and just say, get you to say, yeah, that kind of thing. So at 15:33, I'm going to kick us off.
Cool.
Are we on Horizons channel on YouTube for the live stream?
We are because of what happened this morning in terms of the fact that we cut out. We're not going to take that risk. So what we're going to do is we are still recording this, and we are going to edit and post it up to YouTube on Monday. That's the sort of backup plan. We don't want to take a risk of sort of saying we're streaming it live and then it cut out. I don't think that'll do anybody any favors. So that's what I plan on doing. Okay.
I'll just put Baby Shark on.
Retakes, Ian.
Sorry? What's that, Nick?
Can we do retakes?
Probably enough outtakes over the last 4 days, believe you me. Right, I think, going to kick us off. Okay, so welcome everybody. We've got our final hour and a half. Yeah? So first of all, well done for getting through the last 2 days, all of you. And that's all of you in the teams, and that's all of you coaches, and all of you critical friends, whoever you are out there, and you're joining this Zoom. You have been miracle workers over the last 2 days. So there's a personal thank you from me and a massive thank you from the Horizons team as well. If you didn't hear me say just before, we are not going to now stream this live to YouTube. And the reason for that is, as you know, this morning, we cut out suddenly. We lost connection suddenly this morning. We don't want to take that chance if we're going to stream live to YouTube. What we are going to do, though, is that we are going to record this session. We are going to make a film out of it, and it will be posted to YouTube probably Monday. So as soon as it's on YouTube, we're going to let everybody know. Okay? So I hope that's okay with everybody. I'm going to do my roll call now to see who we've got. And all I want you to say is sort of, yes, we're here. So we're going to unmute you. Yeah? Here we go. So, East of England, are you with us?
Yeah.
Brilliant.
Yep.
We've got East of England with us. Fantastic. London, are you with us? London, have we unmuted the phones, everybody?
Yeah.
You with us as well?
Can you hear us?
I can hear you loud and clear now. Good to have you on the phone, London. Then I want North East. Are you with us?
Hooray!
Right then, that's really good. South East Coast, are you with us? Dean and Co. South East. Dean, I can see you. Unmute Dean. Hello, South East.
We're here. Yeah.
Got you. Brilliant. Now then, this is the one that I'm slightly worried about. Southwest, have you managed to join us? Oh, there's a bit of silence from Southwest. There were people who didn't join us this morning, so perhaps we'll look into what's happened with Southwest over the next couple of days. Do you want to unmute them as well? Okay, we're going to mute some people on the telephone. Southwest, is anybody from Southwest with us on the phone?
Yay!
Yay, got Southwest. Fantastic. We're really glad that Southwest is joining us. Can we remute the phones? Thank you. Right, West Midlands. I know that West Midlands are here. We've got both Andy, Ginny and Martina, I think. Hello, West Midlands. I know if I shout this out, they'll definitely say yes. Hello, Yorkshire. Are you there? Yeah, I knew you would be. You're always reliable, Yorkshire. Now then, I know these people are here because they've been taking the mick out of me. South Central and Nick, are you there?
Yeah.
Get in. So, Northwest, are you there, Northwest?
Yay!
Another one that's there. East Midlands. East, Paul, East Midlands?
Well, I'm here.
Hey, quality, not quantity, eh, Paul? That's the way we look at these things. Brilliant. Good to have you on board. Another special welcome to Scotland who joined us today. Hello, Scotland.
Hello.
Hey, Scotland are here as well. Hello, Wales. How are you, Wales?
Yay!
Hey, Jackie, how you doing? Good. And then finally, have we got our Northern Ireland contingent? Northern Ireland, are you with us? Northern Ireland? Yes. Somebody unmute Northern Ireland. I can see them. Who's going to unmute Northern Ireland? So I think Pardik's done muting you. Got you, Northern Ireland. Hello. Got you. Brilliant. Hello. I think we've got everybody then today, which is great. So what are we going to do for the next sort of hour or so? And if it goes on a little bit longer, that's fine. But I really would like to try and wrap you up before 5 o'clock. So I think you've all worked massively hard. So next slide, please, Paul. Welcome again. I think we've done that now. I think everybody knows who's here. So I've probably said this already, but haven't we done an awful lot of work? Yeah, and we're nearly there. And even somebody like, Obama occasionally goes, phew, yeah. And I think that's probably where most of us are feeling right at this moment, yeah. But also give you a chance to just pat yourself on the back a little bit for the amount of work that you've done, yeah. It's been incredible. It's been overwhelming at times, and you've had me run off my feet, and the rest of the Horizons team are also, been running around an awful lot trying to help and support. You've been absolutely brilliant. But we're nearly there. 1 more hour to go. So let's just have a quick flick to the next slide, please, Paul. So I think we've done the introduction. The main bit is going to be feedback, yeah? And we'll probably spend about an hour doing that. We'll then talk a little bit about next steps, and then we're going to do a goodbye and commitment, yeah? And again, I'll talk you through that. It's very similar to yesterday, but I'm going to get you to do one other thing at that point in time, yeah? And in order to make that work, you need a pen and a piece of paper somewhere about you, yeah? So make sure you've got that to hand when we get to that stage. Next slide, please, Paul. So, what does the second day feel like for everybody? Well, I think it's fair to say that over here in Coventry, we had a few issues this morning around internet connectivity and things like that, and the techie guys here who are sitting around me are shaking their heads. But I just want to say that's fine. These things happen when you're trying to run virtual sessions. You all recovered brilliantly in terms of coping with that when some of the phones blocked up, etc. You have been magnificent throughout the day, yeah? Most of you, do you know what? You just got on with it. That's exactly what we need around an innovation burst. You just got on with it, and you continued your conversations that you had been having. And do you know what? One or two of you sort of said, Ian, I can't do this today because actually we want to concentrate on, I don't know, mental health, or we want to concentrate on well-being, therefore I can't do whatever it is. And do you know what? That's absolutely fine, yeah? You worked on what is of value to you. And that's really important in this. And what we tried to do over the course of the day, and certainly with a couple of groups that I've worked with, is I've tried to sort of get you, if you remember Helen's slides at the beginning of the day, we talked a lot about trying to funnel down some of these wide ideas into something that, started to sort of converge back down again. So we've tried to come back down really. I hope you've thought about your outputs or your products or your deliverables, however you want to call it from the day, my shout out to you is make sure that you send everything in that you have done. Whether it be pro formas, whether it be photographs, whether it be slides, whatever that might be, make sure you send it to your coach, yeah, who will send it on to me. If you can't send it to your coach, send it to me. We want to lose nothing over what you've done over the last 2 days. And I guess we've all been working towards feedback, and one or two of the coaches, if you're a bit like me, you've probably been sort of selecting who's going to do your feedback for you on the various themes. So, next slide, please. So, timetable, we're done. I'm not going to labour that. You've done it all. You've stuck with it, and well done. Keep going, please. So we asked you to think about what your outputs were going to be. I've already said about sending them in, and we're going to go through them in a moment, one at a time. Now, if you think that we are, really all high tech here in Horizons, you can see. I'm going to show you behind me. Can you see that? Yeah, we've got our running order on a flip chart, so we know all in here about what we're going to do. Yeah, and hopefully it's all going to come together beautifully as we run through the various outputs from you all. And what I'm going to do is I'm going to take you through that. Next slide, please. So we're going to do feedback. Yeah. Now, the coaches have had some instructions about how to do feedback. And given the commitment that I just made to try and get you all away by 5 o'clock, yeah, I'm just going to say that if we feedback on 12 things and we do 5 minutes worth of feedback on each one, I'm an accountant by background, that to me is 60 minutes. Yeah, that's an hour. Yeah, so we need to feedback well, but we also need to feedback pithily. Otherwise, we could be here until the early hours of the morning. Yeah. So that's just a plea to everybody that's going to do a little bit of feedback. Just have that in the back of your mind. I don't want you to rush it. I want you to get your points across, but please do not labour your feedback. And I'm going to go through it in the running order, not necessarily here, but actually the running order that we have got behind us here. So the first people I'm going to ask to feedback is Sasha. So I'm going to come over to Sasha, who was doing high volume patient groups. And I think, Sasha, you want us to share some slides. So can we open up Sasha, please?
Yeah, that's great. Thanks, Ian. And I'm going to say very little. Carl and Hayley are going to talk more about the work that's been done by the group. It's been a really interesting conversation. The focus has been on high volume and high resource patients. And Carl and Hayley will say a little bit more about why. Really interesting in terms of availability of data. If this is going to be an ongoing focus, it needs to be easier for people to see what's going on. And there are lots of ideas to share and an emerging network. So without further ado, I'm going to hand over to Carl, who can hopefully be unmuted, and then Hayley's going to bring us to a conclusion. Carl, are you there?
I am indeed. Good afternoon, everybody. I'd just like to feedback what we've been working on regarding clinical pathways. Basically, can you move the slide on one? That's it. So what we worked out with a basic idea is that clinical presentation X, Y, and Z. Currently, we have potential 5 different pathways for clinical presentation X. The idea would be that if we get all the trusts together, all the hospitals together to come up with one single pathway, that would make it easier for all the ambulance services to be able to sing off the same song sheet. So that's the basic process that we were looking at.
Thank you, Carl. And it'll be interesting to see if that's similar experience elsewhere. And do we want to hand on to Hayley? Are you there, Hayley? Can we hear Hayley? There we are. We've gone to the northeast.
I'm moving up. I'm moving up.
I'm going to employ technology, and I'm employing technology. And
Over to you, Hayley.
Can you hear us?
We can.
Okay. So our approach was kind of two-pronged. There's already been some work done in the trust about education of GPs about the categories of ambulances and the skill mix in a crew, and kind of making sure that the appropriate responses are achieved. So we want to expand on that. And then another kind of thing we want to do is with universities and about prevention. So we think that university students are quite a high user of 111 due to not registering with a GP, and then also with ourselves on 999 due to intoxication. So by trying to do a project to encourage registration with GPs, and then also building some links and things with universities to start thinking about the intoxication problem, and we just want to carry it on from there. Thanks.
That's very pithy. Thank you, Hayley. And we've had lots of input as well from Alison, Adam, and Sandy during the call. So a couple of points of more detail. I think the key here is lots of people with lots of ideas, and there's a need for an ongoing network to keep the work moving forward. Over to you, Ian.
Okay, thank you very much to our first group of feedback. Thank you for that, and that was a good role modelling about how to do it, really. So, next one we're going to move on to is mental health, and that was one that I helped coach over the last couple of days. There are, I think, I'm going to hear back from 3 different trusts as far as the mental health bit goes. First of all, I'm going to hand over to London, who are going to tell us a bit about the work that they've been doing with their call handlers around managing mental health calls. London, can you talk us through that for a minute or so, please?
London, can you hear me?
We can hear you.
Hiya. So we've spent the day talking about like a mental health tool to assist us with the mental health card on MPDS. The idea around that is that it will enable us to end calls safely to those mental health patients that don't necessarily need call handlers to stay on the line with them. And we've kind of created a draft to sort of assist us with that, which we can send to everybody if they want to have a look at it. And we've also created a pre-hospital mental health risk assessment tool.
Mm-hmm. So you've done some...
Yeah, so the idea of that risk assessment tool is to kind of give staff the confidence to say, actually, yes, this patient doesn't need to go to ED unnecessarily.
Yeah. So you've done some great work there with mental health calls. Next, I'm going to pass us over to South East Coast, who were looking at potential extensibility of their mental health risk assessment tool. So South East Coast, are you there for us? I think it's Dean.
Tell us a little bit about the design of our mental health triage tool and how that's been implemented.
Yeah, so our mental health risk assessment tool was originally designed in collaboration between CCAM and St George's University in London, with a view of it being used by our specialist paramedics within our clinical management plans. A few years later, this was then expanded and adapted for other frontline clinicians. We now have this electronically on our iPad devices across the trust through the JR Calc Plus application. So it's all of our specific guidelines and also the full risk assessment tool. We support that heavily with clinical education. So it was featured on our key skills, our statutory and mandatory training for frontline staff, and also all new members of staff that come into the organisation have training around urgent care, which includes the use of the risk assessment tool.
Excellent. And do you know what? There's real interest in the mental health group about taking this tool and making it extensible. And indeed, one of the 2 of the trust today, actually, we think we're going to try and connect up after this in order to take that one forward. So it's really, really good idea there. And I'm going to hand over finally, I think, to Ginny and Martine from West Midlands, please. So Ginny and Martine from West Midlands, you're going to talk about the mental health.
Hear us okay?
Yep, can hear you loud and clear.
Okay, that's lovely. Okay. So basically, we actually do use the mental health tool over in West Midlands, and we have them for a number of years. We find that it's safe next to crews and helps us make out with our decision making. The hospitals, to our knowledge, they don't actually use our tool. However, it does help us obviously with with the care for the patient, and obviously we bring it to their attention once we're at the hospital and what kind of risk we think they are. They have their own AMHAT team at the hospital that they deal with. This is certainly good for us, and obviously to show the severity or how much the patient needs help with their mental health. It also highlights the risks as well. It's numerous questions. We are electronic now on the UPRF. Now I believe that they don't, although they don't actually use this information, their own GPs can access the information, and a mental health nurse can as well if they request it. So it is all actually on their file should they need it in the future.
Also, we were going to talk about safe havens, which we think would massively help in our area, maybe in every locality. But what the things that we think it should be is certainly 24-hour point of contact. It has to have volunteers for it to be 24 hours, but having trained mental health workers, social workers, paramedics, ECPs, it would all go hand in hand to give people with mental health problems a place to go. It needs to be in multiple locations, in different localities for it to work. If you've just got one place in one area, it's just not going to have the capacity to hold everybody. It will then help self-referrals for mental health patients because they can just walk in whenever they need to, and it will help with ambulance referrals, which in respect will give the patient the right referral, less 999 calls, reduction in A&E admissions, and it would also free up the police. We also thought that it would be a good place for the mental health car to be based, and that would be their base to then go out to the calls. It needs to be relaxed, welcoming, almost like a retro coffee shop type place, because then people are going to feel safe, but obviously it needs to be alcohol and drug free. It needs to be open chat. They can just chat if they need to, because majority of the time that is what they want and what they need. But I think with ambulance staff being on site, being exposed to it, it's going to help with their training, but we would also make specialised training for them as well, to be in this environment.
Ginny, Maxine, Martine, thank you very much for your feedback. That's mental health. Thank you all. That's wonderful. Thank you. Next one, I think, is now use of technology. And I believe, Dominic, are you going to feedback on that one? So I think my colleague Dominic is going to do that.
I'm going to be handing over to Tom. So technology is obviously a theme that sits across a number of these ideas that we've been talking about over the last 2 days, and I think it's a concurrent theme that's coming out of the Carter report as well, for those that have managed to have a read of it. But there's a number of infrastructural things that I think we need to get right, and the people that have been joining us for the last 2 days have been discussing that. Tom, are you on the line? Can I unmute you, and are you okay to feedback on some of the stuff that we managed to discuss over the last 2 days?
Yeah, sure. So me and Dom had a really good, productive conversation, and we kind of both came to the agreement that we don't feel there's any kind of quick, easy wins with regards to technology, both regionally for trusts and also nationally. It's quite a mess and it's really complicated. So I think if we were to try and look at what's going on really well within individual trusts and try and replicate it on a bigger scale, we may not achieve that much. So we were kind of in agreement that the wins with regards to tech is more a sort of strategic level, with regards to sort of engagement and sharing of kind of best practice and ideas. So we came up with a couple of ideas. The first was setting up a system or forum in regards to like roadshows. So almost each trust nationally taking it in turn to invite everyone else in for, I don't know, a day or a couple of days, to share what's going on with regards to technology in their service. And we felt that not only at a higher level would that allow some sharing of knowledge and experience and kind of a collaborative approach to the future direction, but there's other benefits. So I think there'll be certain tinier, smaller things where we'd be able to actually advise other trusts, don't do this or do that, because we've learned from that. So sort of preventing duplication. The other building off of that is looking to initially kind of buddy up trusts that are kind of going down the same journey. So, for example, CCAM and NIAS, with regards to our systems in 999, 111 and EPCR are exactly the same. So at an exec level, we've got an agreement that we want to kind of buddy up and do that together. And I think there's potential for other trusts to do similar. We talked about overall trust collaboration and sharing of current progress, including things like GDE work. And then finally, looking to start building on a potential national, kind of nationwide data set. We're aware that with a lot of developments and pilots, we struggle to make them business as usual because of providing the data and the evidence behind it. And that's because we're all documenting and recording things in different ways. So if we were able to, between ambulance trusts, have a nationwide data set, and ideally like a single repository for plumbing all that information into, then we could share best practice and developments between organisations. And I think that was kind of Dom's summary of what we discussed, really.
It was, yeah. And thanks to colleagues as well, David Morgan and co, who helped that conversation. And I think what's really coming clear is that, days like today today's like today and yesterday are really just the start of this, and we need to be able to create more opportunities like this where, as organisations, we're communicating more about the infrastructural needs that we need for frontline staff and also our patients. So thanks to everybody that's been involved in that, and obviously looking forward to what we can do over the next few months around the outcomes of today.
Thank you, Dominic. I think that's going to be a continuing theme about keeping those connections going across the service, even after this particular innovation burst. I think that's something we need to come back to.
Yeah,
sorry, Helen, go on.
It's Helen. Yeah, can I make a suggestion? Hi, everyone. What would be really great is, like where we're listening and lots of us are hearing these ideas for the first time.
Sure.
What would be really great is can we put some comments in the in the chat box as well. So, for instance, our colleagues from Scotland just made some really helpful comments about mental health. So if we can contribute in the chat box as well while we're listening to other people, I think that would be great.
Oh, good idea. We should have mentioned that at the very beginning. Yeah, thank you, Helen. So I think I'm going to move us on to engaging communities and engaging the public. That was one of mine for today. I've got a couple of people lined up who want to talk back to us. I've got South Central and North West. I'm going to start with South Central. We're going to talk about the potential extensibility of the SCAS Kids website. So can we find, I think it's Nick from South Central, please.
Yeah, okay. So, we wanted to share with everyone else a tool that we've developed to engage with one segment of our community, that's children. We get loads of requests to visit schools and other young people, scouts and guides and so on. And of course, we just don't have the resource to fulfill all those requests. In fact, probably can only go to a minority of them. So we developed SCAS Kids website, which is basically has lots of resources and games and fun things for kids, but allows us to get sort of key messages out to them about their health and what to do in the case of a medical emergency and so on. And it's been a really successful way of engaging with that group, where we just don't have the resources to engage with them directly all the time. And so today we spent some time looking at how that might be extensible, and we looked at two ways really. One is to other audiences, other segments of the community. So we gave some thought to who are the people who most often phone 999. Especially when it's not actually the appropriate call to make. And so we looked at a few other audience segments. So young families, families with young children, the elderly, ethnic minority groups, especially there because, there can often be language problems as well, and also carers. And so we spent some time looking at those different groups and thinking about how, you know, a website might achieve the sort of engagement that we managed to achieve with SCAS Kids. We also have SCAS Youth, which is aimed at teenagers, which is just coming online now. We haven't actually promoted it yet, but it is up. And then the other area we looked at was whether it was extensible into other trusts. So SCAS Kids, you know, we're more than happy to share the content and even the code as well. SCAS Kids was developed entirely in-house, so we own all the code and stuff, and we're more than happy to share it. I mean, I'm not technical. I'm not a very technical person, so I don't know the practicalities of doing that, but any other trusts that are looking to do something similar, we're very happy to help with that. So whether it's just a case of rebranding what we've got or whatever. But I mean, I think, I suspect that all trusts will have requests coming in from schools to do visits and stuff. So there we are. We also briefly looked at other channels like Snapchat and Instagram and what have you. So have a look, if you haven't already, at scaskids.co.uk.
That's fantastic. Nick, thank you so much for your feedback. You know, there's an offer there to share that out across the service, and certainly I think that's something that probably other services will be interested in taking up that offer as well. I'm going to now hand us over to, just quickly, to Northwest, who are just going to talk a little bit about streamlining of comms and co-production. So can we open up Northwest, please? Yeah. Northwest, can we hear you, Northwest? Are they on the phone? We're struggling to hear Northwest. We might have to come back to Northwest, I think.
Hello, can you hear me now?
Got you, Northwest. We've probably got about a minute and a half. Would you want to talk us through, please, your streamlining of comms and co-production?
Okay, so I don't know whether you can see the poster we sent through, which is a summary of our discussion and our kind of mind mapping outputs for today and yesterday.
Yeah.
So we looked at why we engage. Obviously, there's an obligation to pay. We have contact with a lot of people, so there's lots of opportunity to engage. And obviously we need to support operational demand. We can't continue to send ambulances, and there's so many information messages we can give out to people on that. So we looked at our audience. We could tailor our audience down in a variety of ways, so generation or traditional kind of stakeholder groups. But we looked at members of the public who have never had to call us but could at any time, who will need information on where to go, etc. We looked at members of the public who regularly call us, and I'm not necessarily talking about kind of frequent flyers, but these are people who have lots of conditions and need help from us. And then we also looked at a third category of audience, which are our future users, predominantly children and young people who will grow up to be the users of the future. So we felt that's a real key road into engagement work. So the approach we used was to look at how we could develop a network of engagement champions or advocates where we could make every contact count. Basically, there's a huge amount of engagement work taking place across the trust through different teams in different departments, but we felt it's disjointed and ad hoc in terms of its message, whether it's reactive, proactive, etc. We have a successful approach already being used through the MEC approach via our patient transport service. We give out public health information, and we felt that there was a real opportunity there to build on that. So we could bring all these people together, provide more consistency, more streamlining, and more tailored messages by using this network approach. So how we would do that: undertake an engagement audit to begin with to see actually what we are doing, what we could do better, using the A of the ACE acronym In terms of actions, we very much want to build on that MEC approach, as I say, by using our existing volunteer car drivers and our community first responders who are ideally placed in the community to give out other health-related information. We could develop key messages and materials working with other colleagues and very much using a co-production approach with community groups to target messages and materials to community needs. And then we could create a resource portal both for internal and potentially future wider ambulance colleague usage, where we could develop materials and share them. And then we've also done a little bit of mind mapping, which kind of gives you a little bit more detail of the types of approach that we felt would be helpful. So workshops, use of social media, database of volunteers, how we attract those, how we make our materials accessible, and how we can promote that and use sort of national resources to get better impact and reach. That in a nutshell is it.
Thank you very much. Thank you. And a beautiful poster there that's been designed and shared, and we'll certainly take that, and we'll perhaps have some further conversations with you afterwards as well, Northwest. And thank you for getting over your tech difficulties over the 2 days. Really appreciate you being with us. I'm going to move us on then. Next, I think that we are on to well-being, and I'm going to hand over to Rosanna now. I think she might be introducing Ollie and Emma. We're doing okay for time, but if we can just keep things ticking over, that would be great. So Ollie, Rosanna.
Hi everyone.
Hi, is that Rosanna?
She seems to be muted.
Rosanna, are you muted? Here we are, you've got Rosanna. You're on, Rosanna.
Oh, great. Sorry, Ian. Yeah, so we have had loads of different people involved in discussions over today and also yesterday. Only today there's been a number of different voices coming into this from the east of England, North East, West Midlands, Yorkshire, Northern Ireland as well. But the two people who have put their hands up to give us some feedback today are Emma from the east of England and also Ollie from the North East. And the two ideas that we want to kind of present to you are the peer support model idea and also a wellbeing app, which has been developed in some areas. And what these two ideas really speak to is the overall goal to make sure that we build personal agency for taking action for our own well-being in the workplace, and also provide out-of-office support and access for paramedics. So I'll hand over to Emma first of all.
Hi everyone. Yeah, so we, as Rosanna says, we've split into two main groups really, looking at peer support and the wellbeing app. So in terms of peer support, I think it's fair to say every organisation has some form of peer support, all variations on a theme. So TRIM is huge at the moment in a large number of organisations. Things like wellbeing champions and staff advice and liaison roles. They're all a voluntary type role from existing staff in different areas. And I think it's important to note that nationally, a couple of months ago, there was the start of a peer support forum under the National Director of HR Group, looking at how we can standardise elements to make sure that that things are consistent in their approach. So we've looked at various models and flow diagrams that different organisations input into the 2 days have got. And I think that the main output desire from us is to establish a best practice framework for peer support, specifically looking at elements of how we recruit individuals into those voluntary roles of peer support, making sure that they have the skills and the capabilities to deliver that role well, looking at a kind of standardised training package for those peer supporters, so that staff are receiving consistent levels of high quality support in line with best practice. Looking at the ways in which peer support's utilised, both in terms of recognising proactively by the trust people and staff to that might require engagement with peer support, through to the way the options and opportunities that peer supporters have in terms of providing information and wellbeing support. And then finally looking at the welfare and supervision of those individuals in those voluntary roles, because there was a lot of talk around recognising that not only have they got their own role to manage their own well-being in, what they're having is receiving stories and information and requests for assistance from other staff. So looking at how those individuals are well fed themselves. So I think in terms of the aim would be establishing a best practice framework for peer support. The other element we focused on was a wellbeing app. There seems to be a lot of drive for that, so I'll hand over to Ollie in terms of that concept and how that could be moved forward.
Thanks, Owen. Yeah, so we looked at the formation of an app for the staff to be able to access it. I'll try and keep it quite brief because it can get quite in depth. Essentially, what it will do is it's not designed to distract staff having contact with services.
Can't quite hear you, Ollie.
Is that better?
Yeah, you need to move a bit nearer your microphone, Ollie. Okay.
I'm practically sat on my laptop. Yeah, sorry. So as I say, that the app,
that's much better.
The idea for the app was that we wanted to give staff the ability to access services surrounding wellbeing directly themselves, rather than having to rely on waiting for managers to put those referrals in. So just from that slide that you can see there now, we sort of looked at these areas of what we considered were potentially good to go into the app. It's not an exhaustible list, so there could be scope and development to add more and more, but depending on what the sort of preferences and desires are for each trust. So we looked at elements to do with sort of the counselling, peer support, and integrating that into the app. Occupational health services, MSK specifically, physiotherapy services, policies relating to wellbeing and general information on wellbeing. So if we just pop to the next one, thank you. So yeah, so just some ideas that we thought we could put under each of those headings. So in terms of the counselling, we'd be looking at staff being able to self-refer for things like bereavement counselling, behavioural counselling, so that's looking at areas surrounding PTSD. Mind as a charity, being able to access them, counselling following trauma from jobs that they've attended at work, or just general traumas that they might have experienced, as well as accessing people like Samaritans. So under the policies element, we thought it'd be quite a good idea, because what we find is a lot of staff say, I'm not aware of the policies surrounding certain things, so we look at what policies do with well-being. We could potentially put either abstract or the full policy there, and so there's a short list there of what we could do. In terms of the peer support, and just in the conversations that I've had with Rosanna and Emma today, it's just things about having sort of like if there was a single duty number for a peer support group, if it was operating 24 hours, is having that number available, and then also a directory of people who are trained as peer supporters, what their remit and responsibilities would be, as well as having a full list of contacts for various managers, from sort of duty managers to operational managers, etc. Under the occupational health thing, this is where we thought the staff could do self-referrals. So what they would be able to do is go onto this app and refer themselves for elements that are sort of held under the umbrella of occupational health. So the smoking cessation, which is obviously a big drive nationally within the NHS, things like auditory assessments, to put themselves in for hearing tests. The well man, well woman is something that we can offer as well as GP services, but again, it's delivered through the occupational health. And then things like if they feel they need vaccinations or blood tests following needle sticks and things like that, they can self-refer directly into that without having to wait for a manager to be available to provide that referral. And then under the general wellbeing information, that's any other information really that trusts want to put in, such as sort of current campaigns and drives that they might be doing just within their trust area, or that might form part of the NHS England's sort of current campaign schedule. We looked at this as well just for the responsible employers element of just having a reporting system on there so that we can derive some kind of feedback and report system so that if staff are accessing counselling, it contacts a duty manager so that there's an opportunity for the managers to go to that member of staff and just do a sort of a welfare contact and just ask if there's anything that the trusts can do to support them. Obviously, with the relation to the occupational health and the peer support and the policies, those kinds of things, there's an element of reporting that we can do there. We need to just establish how far we can go with that reporting so that we're not infringing on employees' right to privacy and so on and so forth. But it's certainly an app that currently, as we've looked at it over the last couple of days, it's been quite good, and the feedback we've had has been quite good, but the potentials with it are exponential. So thank you.
Thank you very much, Ollie. That's really good of you, and thank you for taking us through the app, which sounds like another great idea. I'm going to move us on. Don't forget the chat room. One or two people are putting some things in the chat room. We'd really like a little bit more in there. I think we're moving on now to Make Ready teams. I believe Andy Proctor is going to feedback. Andy from West Midlands. Andy, hi.
Hiya. Yeah, I've got a stopwatch, so I will keep on track. So our small dynamic team has looked at Make Ready. We looked at what Make Ready is, being a system to ensure ambulances are clean, appropriately stocked and ready for patients. It helps to improve the availability of ambulance crews and to also further reduce risk by ensuring stock and equipment is in date and regularly serviced. We focused on getting a baseline of what Make Ready is, and obviously that's been included in the Carter review today. Now, Carter did include 16 references to Make Ready, and one of the references was a case study from West Mids, because we have a fully implemented team. Now, some interesting stats for those that love a good stat. The case study found that Make Ready reduced clinical hours used to prepare vehicles. Clinical hours being those frontline ambulance clinicians. It found that clinical hours used to prepare vehicles was reduced by 60%, which equates to 18,000 staffed vehicle hours back into the system, which is over, just the number does mean something, 1,500 extra 12-hour ambulance shifts a year. So just that has so many unintended consequences of people can do clinical things. And people can have a bit of downtime, and people can do CPD and see their line manager and actually have a meal break. So that has a number of positive and constructive downtime. So we talk of downtime in a negative way, well, that'd be a rather positive way. So we looked at what we sent out responses to see what other ambulance services did. And it's very clear there is incredible variation across the country, as what we've come to expect from ambulance services throughout ProjectA already. We had 11 responses, 7 have a form of Make Ready and 4 do not. And there are 3 providers that use external private companies rather than in the 4 that use their own internal staff. Now, Carter review looked at the Make Ready and in particular the hub and spoke model, and a trust that implemented that reduced operational estates by 72% to implement Make Ready. Well, clearly that has an impact on the running costs, the maintenance spend of older vehicles, because we need to ensure that the estate is fit for purpose for people making vehicles ready inside vehicles, inside the site. The unintended consequences are reprofiling of shifts, so we can get that flow of shifts in and out through the Make Ready system, ensuring that is better. And we believe a national forum, a resource centre of where Make Ready information is available and share practices will help improve and share what works in some areas and not necessarily for others. I am 3 minutes 17.
Andy, well done. 3 minutes 17. Very good. So that gives us a little bit of time. Thank you very much. Lots to do then in terms of Make Ready, and for not doing it at the moment, I think it'd be interesting to explore those with those four at some point as well. So I'm actually probably going to make us up a little bit of time now, because I'm assuming that we're going to move on to fast track care for carers. We've had our colleagues from ACE have started this today for us. So that's a combination of, I'm sure you know them, Hilary Pillin, Steve Irvin, and Anna Parry. And they've just started to think about what's going on out there and what is the process that we can potentially use to start engaging trusts in this particular initiative and scheme. What we would like to do is we've got a conversation scheduled with ACE over the next couple of days. The proposal is that we talk to ACE, Horizons do, and that we work out a method about how we move that particular theme on a little bit more with you over the course of the next 2 or 3 weeks. So it's a process that started, probably the one that we've probably made the least progress with over the 2 days, but that's fine. There's always going to be 1 or 2 that where we don't make as much progress as others, but we've got a little process now in terms of what we're expecting to follow. So I'm going to move us on then, and I think we are now on improving handover. Pat O'Connor. Pat, do you want to talk to us, Pat, about improving handover, or are you going to get somebody else to do that for us?
Yeah, hi. I had a great conversation with the team in Northern Ireland, and like
train will be travelling to Birmingham New Street, calling at Birmingham International.
Can we mute people, please? Can we get Pat to start again, please? Obviously, somebody's on Birmingham New Street Station then. Pat, would you like to start again for us, please?
Yeah, no problem. I had a call from Northern Ireland, and they've done a bit of work on handover. I don't know if there's any other teams on, Ian, that want to talk about handover, but I know Northern Ireland would like to share what they've done.
Okay, shall we ask Northern Ireland? Can we unmute Northern Ireland and let Northern Ireland talk to us, please?
I'm speaking. Can you hear me okay? Hello?
Yeah.
Sorry, I can hear Northern Ireland loud and clear.
Great. Can I have the next slide, please? We had, the first day I was really looking at the process, the full process of handover from ambulance to trolley, and looking at the patient flow and identifying where the barriers were and seeing if we can overcome some of these barriers. We actually took it back to the beginning and actually tried to define what handover is. We found that there was a disconnect between ambulance staff and also hospital staff, and even within certain EDs, individual triage nurses have different perceptions of what a handover is, and within the trust there's different perceptions as well, different ambulance staff. So the first step is really to define what handover is, because there's a lack of clarity, and there's also a lack of data with ourselves, because we have data in relation to arriving at hospital and clearing the hospital, but there seems to be a degree of a grey area between the two, and we need to clarify that and really segment out the data to move forward. So go on to the next slide. So what we want to put in place was a definition of handover, the actual steps that were involved in terms of the physical handover to the patient, the verbal handover to the triage nurse, but also the documentation and the equipment retrieval, and really to try and define what it actually means to hand over, both from our perspective as ambulance professionals, but also from the triage nurse perspective, so it gives clarity. And then once we have that clarity of definition, to look at the actual handover process, and look at maybe going in and observing the handover process currently, identifying what that process is, and then to actually communicate that process through a poster and through communication within the hospital, so that the ambulance staff and the triage staff are very clear in terms of what a handover is, what the handover process is, and from that we'll be able to look at IT infrastructure. So we'll have a button or some form of IT infrastructure that will have a specific handover time that is agreed by both ambulance staff and also the triage nurse, and then we can use that data going forward. Go on to the next slide. The benefits overall: decreased handover times, and then increased ambulance availability. which also an enhanced patient experience to try and clarify the process and streamline the process. It also will help us going forward in terms of accurate data capture and increase staff morale and satisfaction. So both staff understand and very clear in terms of what a handover is and what the process is. And there's also consistent language within the service and within each individual ED and across the trust. And the next slide. And so overall, how we're going to measure it is actually go into one emergency department with the handover definition and a poster communication and other communication to define the handover process. We get instant IT feedback. We'll do further observations and then roll it out on a regional basis across the trust. And that's me.
Thank you very much on handover. So a lot of good work done on handover. Pat, is there anything else you want to say, or are you happy to hand it back to us at all, Pat? Can we unmute Pat again?
Because I'm very conscious of time, Ian.
Okay, no worries. Thank you, Pat. Thanks for all your help today and helping with that one. Next one then, we've got falls, and I think we've got one or two slides from Diane on falls. So if we can go back to the main slide deck, which I think we've got. Diane, falls. Can we unmute Diane, please?
Yes, hello, I'm unmuted. Hello, everyone. Well, it's been my honour, excuse me, to coach the team working to improve the response to patient falls. The works involved 6 trusts yesterday and 5 today, and at different points has included work from 15 people, so thanks to everyone for that. So we have 4 slides. I'm just going to present the first one as introduction, then Jackie from Wales will take us through slides 2 and 3, and then the final slide, Ben from EMAS and Dean from South East Coast are going to outline our 2 offers or suggestions to take forward. So, well, what have we been doing? We've been making connections, we've been sharing and using information, including the WAST Falls framework. Just a personal comment, I've been really struck by the spirit of collaboration and the openness to both share good work, but also to receive it and to use it. It's been really fantastic and has already produced some real benefits from within the team. So the teams have separately reviewed the WAST Falls framework to see if it offers a basis for a standardised falls framework. That's what we were looking for, and we find that in fact it does. And today we've tested it as such by using the framework locally. The teams have used it to identify their local activity and services, and really just test out to see if it's useful for them in their setting. So with that, I'll pass over to Jackie now, who's going to tell you about the framework.
Hi. I think, yeah, falls has been a major issue for many years now and something we've all been working on. So it was really good to come together today and see that there's lots of initiatives, lots of pilots, lots of things going on, but we haven't still quite got it right. I think we all know that falls is high demand. It's the second highest demand in Wales, second to breathing problems. It's complex. We have people with health and social issues, and we have people laying on the floor for literally hours on end. So it is a major issue. And we thought, well, there's lots of stuff, good stuff going on, but how are we going to bring this together? So just so happened that in Wales, we've quite newly put together a WAST Falls framework, which you can see in front of you. And it's literally going to be going to the Public Health Wales on Monday. And all it's doing really is what we wanted to do today and bring everything that we're doing together with some semblance. So you can see there, it's sort of from prevention, and it's 5 steps right through to avoiding further harm. So on the next slide, within the framework, we've got a nice driver diagram at the back, just to sort of cover really the 5 steps. So looking at prevention, which in Wales, you know, we're sort of working again with Public Health Wales. Our patient care services are responding to patients and reporting back if there's any issues, so we get social care involved. The supporting community resilience, I think West Mids will see their assessment tool at the top of that, which we've adopted. Thank you. And also working with residential homes. So there is some evidence as well to support all this in some of the pilots that we're doing. And in relation to the residential homes, it's basically lifting aids within the nursing homes. They've taken this on themselves really, and it's very much funded collaboratively. This was based on the frequent callers data that we had, so we focused on the main homes that were calling us quite often and managed to reduce the call rate by 40%. Assessment in the Hear and Treat, we're looking at the clinical desk, NHS Direct, and they've got an algorithm in place so they can prioritise the calls in relation to the next step, which is response. So the response model is sort of 1, 2 and 3, which 1 being no injury, 2 being minor injury, and 3 being, you know, response to hospital, to take them to hospital. And then to finish off with avoiding further harm, so falls pathways in place and working with a pressure sort awareness strategy as well. So I think really for falls, we're all doing an awful lot of work, but we really need to take this forward now and step up and have some sort of UK work or structure or framework going on. So I'm now going to hand over the next slide to Ben from EMAS.
Yeah, thank you very much for that, Jackie, and thank you for sharing the framework in the first place. I'm going to reiterate a bit about what Diane and Jackie have already said, and that the first point of that has been that this has just been a great networking experience, sharing the knowledge of many services to one goal. If we look at why we're looking at this area, as Jackie's already said, top or number 2 reason for calling the ambulance service in Wales. At the moment, it's number 1 reason for EMAS, and I think if we look at all 10 trusts, we'll find that falls will appear somewhere in the top 3. But the question from that comes, are they all appropriate for their 999 ambulance service? And I think we all agreed as well that they're not. Those that do come through to us are often low acuity, so they're left to wait, and they tend to deteriorate. There's quite a number of those calls raise up and become a higher acuity. Then we're talking about things like pressure sores, pressure damage, long lies, and things like that. And also we have a bit of a problem with how the public conceive us when we're leaving an 85-year-old on the floor for 6 hours, 7 hours. The question is, should that call have come through to us in the first place, or should it have gone elsewhere? So what have each of the trusts been doing? Well, each trust has individually looked at prevention, call allocation, resources, cars, and whether they have paramedics or technicians, ECAs, whether they have MDTs on board, so occupational therapists, physiotherapists. But what we're finding, and this was certainly true for EMAS, it's often a short-term commission. We're not getting the support from the CCGs. We're each looking at training and assessment of our clinicians, and frailty is obviously something that in EMAS we're looking at quite strongly at the moment. And we must remember that falls are often a syndrome of frailty, and also the community partnerships. But each of these initiatives has often been in isolation and not brought together, which is what the WAST falls framework does so succinctly. So if we look at where we can take this, if we nationally all agree to the same basis, the same framework, which then can be personalised and undergo some localisation, and network share that information between ourselves, we can overcome the barriers to putting these pilots or projects into full-term commission. And part of that is going on to what I think Dean's going to talk about next. So if I can hang on to Dean, or pass on to Dean.
Hi guys. Yeah, so I think just to sum up what the other guys have been saying, nationally we've all got small pilots, small pieces of work going on around falls, lots of really innovative stuff going on, but actually a lot of the time we struggle to transition from that pilot phase into business as usual. And actually there's some of us that are probably failing but not learning from each other's failure. And we recognise that one of the really useful benefits of the last few days has been all the networking that we've managed, and actually we should continue that momentum to make sure that we sustain that learning and energy. And in order to develop a national framework, in order to maintain strength in numbers, to put some power and some backing behind whatever we develop, the group felt that it would be useful to develop a community of practice around falls, and felt, as it says there, that this should be a light touch community of practice, not weighed down by an awful lot of governance, but just a useful forum to share our successes and failures nationally.
Thank you very much. Thank you very much, Dean, and thank you very much for everybody around the Falls programme. There's been some great work there, obviously. Now then, I'm going to move us on now to Productive Ambulance. I think that's over to Bev. Bev, are you going to talk us through Productive Ambulance, please?
I am. I just need Paul to stop sharing his screen, please.
He's doing that now.
Fantastic. And let me share mine. So this one will be potentially quite quick, not only because I'm from the West Midlands too, so Andy and I talk very quickly. We started off with the why question, the same as everybody else, and the Carter report published today added to the kind of crystallisation of the thinking, and we felt we needed a productive ambulance service approach to improve safety, to reducing unwarranted variation, waste, and avoiding duplication. And those were the key areas that a productive series approach kind of focuses on. So we looked back at the existing work that's been done mainly between about 2007 and 2011, and picked a couple of the kind of areas within the existing ones, just to think through and see if they applied to the ambulance services, and developed our own prototype, which I'll share with you now. But I just wanted to say a huge thank you to Carol and to Sarah in the Northwest, who we have done most of this without visual communication, so a very old-fashioned way of working, but they created the first prototype, which was the hardest bit than starting with a blank piece of paper. So this is the prototype we've got to by the end of the 2 days. A lot of our focus and conversations this afternoon have been about the foundation level being really core, and initially we had technology at the bottom, and it's been really interesting listening to the conversations before ours, because we've actually flipped them, and we felt staff well-being and the 3 foundation components were actually really key, and technology needed to thread through everything, because if we depend only on technology, we probably won't start many things or everything, whereas we can still do stuff without technology. It's there to enable us. So this is our prototype of what it might look like. It works, the productive series works at 3 levels, so foundation, planning and delivery. And our real kind of premise was that if we get the foundation right, the others actually build on them. We spent a bit of time talking about what its kind of brief might be around its geographical or patch area. So we moved from a productive ambulance station to productive team or a productive service, and a productive service feels about the right level. And then if you look into each of these boxes, we started to map through some of the things that we had been hearing yourselves talk about, some of the things in the Carter review, things that the teams had all put forward, you know, like the staffing, equipment, brakes, the make-ready vehicles, rotation, staff retention, interoperability, data was pretty key, and then looking at you know, kind of the most work that we've done was around the well-organised working environment, so stock levels, checklists, standardised stocking station, standardised stock in the vehicle, and also looking at the quality visits that you do, so not only doing them but also the feedback and action from them. Safeguarding came up quite a bit, and the paperwork and the connectivity of the information through that. So that's kind of some of the framework of where we got to. And I'm just going to ask Pat to add in a few words at that point.
Yeah, thanks, Bev. What we tried to do was actually think of practical things that on this second slide, well, what is it, 1, 2, 3 now, on the third slide, about what we could actually do so that we can start moving into an action phase rather than think about the bigger picture, which is really easy when you look at the first house model. So we started to put that in list form in these boxes. I'm not going to go over it every box, but I think it's something that we can share and think about as we move forward into next week. And we really want to start conversations now in the latter part this afternoon, as Ian said, thinking about what action can we take next week, even if it's a small test we're going to do.
Brilliant, thanks Pat. And then our final slide. So we've been quite an emerging group, and we've gathered people as we've gone along, so quite an organic group. So I just wanted to say a little thank you to everybody who has scattered their fairy dust over this quite complex piece of work and made it great fun to work with. So thank you very much.
Wow, an absolutely fantastic start to that. I think that's going to be a growing piece of work over the next sort of 6 to 12 months. So thank you very much, Pat, and thank you very much, Bev, and everybody else that's contributed towards that from the services. Next one, I'm going to move us on quickly because I'm aware of time, is Jude and rotation. Jude, are you on the line, Jude?
I'm on the line, yes, hello. Rotation, we kind of merged a little bit with what Bev was doing, but there's something that I'd like to share. First of all, to say we had 5 ambulance services involved in this, and we had a bit of a Twitter storm last night, so thanks to everybody that's got that energy and that sense of, interest and, sense of urgency about doing something around rotation, because it's such a fabulous thing. I was talking to somebody from the ambulance service who said, I can't imagine 10 years ago having a job as interesting as this, and rotation has made my job interesting. It's going to make my job even more interesting. We realise that there's lots of different states of rotation for paramedic staff up and down the country, and I asked for a few volunteers, and I don't know if they have time to ring in. Maybe Spence, maybe Christian, maybe Karen, maybe Adam, maybe somebody who might want to just share a few ideas of what we've been doing today. Can I have any volunteers?
Hi, can you hear me?
We can hear you loud and clear.
Hi. Just to quickly talk about the rotational paramedic scheme. Currently, one of the trusts that are involved with the pilot with HE, and I think it's going really well anecdotally from our specialist paramedics that are currently involved with it. I think the idea behind it was we could put the paramedics in a different care setting to enhance the skills and increase staff retention. I don't think we have any data to suggest that that's happening yet, but it is in its infancy. There was some discussion about the rotational not just being applied to paramedics, but being applied to non-registered staff as well. How that would look, I don't think we fully know yet.
Thank you. Thank you. So just to say, we had a few quick wins. We said maybe a how-to guide, maybe a second quick win might be who's doing what nationally, just some kind of like resource guide. Third thing might be top tips on how to sell paramedic rotation to commissioners. And the fourth top tip, of which I'm sure there are a lot more, would be an opportunity that everybody was saying, come and see what we're doing in Links, come and see what we're doing in Northwest, come and see what we're doing in Yard. So there was a real energy for sharing and collaboration. So I think that's us on rotation, very energetic, very enthused group. Thank you.
So a huge word of thanks there from Jude, from all the enthusiasm that everybody's put into rotation. Again, I think there's something there for us to build on. So thank you. Last but not least, so we're now getting towards the end, the final one. I'm going to hand over to Helen, who's going to talk through the massive amount of work that's been done over the last sort of few couple of days on quick wins. Helen.
So, so me and David Morgan are going to do a double act. And David, can you hear me?
Yes, we can, Helen. Can you hear us?
Great. Yeah. So Paul's going to move the slides for you. So David's going to start, and I'm going to finish.
Right. Thank you, Helen. So basically, from June, I think it's always been the vision, definitely of Helen and the Horizons team, and myself, that there was always going to be some quick wins. And the reason there was going to be those quick wins is because the population that were at London and on the ProjectA crowdsourcing site were the people that come across these problems. So we had the ideal audience to provide the quick wins. Can we move to the next slide, please? It's these small little things which, even from today, we came up with 3 or 4 more little ideas that we'd never even thought of. A couple, again, I think the common theme is sharing amongst other trusts. So speaking to Yorkshire last week, they use something that East of England do, of putting the PIN number of the ISI radio in the front of the vehicle to save time from the crews being in control, to ask what the paramedic on scene may require. It's all these tiny little things which are now starting to add up, and the vision will be to have some dynamic, fluid, evolving directory that all of the trusts will be able to use and utilise, update, and continually run for, well, not just ProjectA, but ProjectA 2019, ProjectA 2020. Can we go to the sort of ideas that we've come across? So we came up with a list of about 10 that we think were literally quick wins. In other words, let's get them in now, let's get them in practice, get them tested. We're not going to go through them all. However, the number 3 on that side is we no longer have fuel cards which were attached to the keys. So you want to show me those keys. So when you go to the station, they no longer have that little tag on, so you don't know which vehicle you're trying to get into, which can be frustrating. And the worst way to start off your day is frustrated. And number 4, the thank you cards. We've sent some out as a test, and we've actually had our first feedback, which might be our new ProjectA catchphrase. And apologies for the accent, but the feedback was I think it's bloody lovely, which was actually quite nice. So that little tiny message is something simple, but I think something which is the start of the bigger thing, which this quick wins will always be. And the next iteration of the thank you card might be an all singing, all dancing, but let's start where we need to start, and hopefully we will evolve from there. I think that's hand over to Helen.
Yeah, brilliant. And no, thanks so much, David. And what was lovely was that a number of the other teams have given us some more quick wins that came out of the last 2 days as well, and we want to include those. So if I can have the next slide. You know, so the whole kind of idea of this is marginal gains. You know, if we can find lots of little things that will make a 1% improvement here, 1% improvement there, then actually all the little 1% add up. And if you compare it, you know, to things that are like annoying and frustrating and time wasting, that all create little declines. So, you know, like the thing that David just talked about with the keys, you know, every time that happens, it's creating a decline. So actually, if we can start to do this, so it isn't just, you know, a group of things that are in a directory, but a kind of mentality. Actually, what you find over a period of time is the gap between having a 1% improvement and a 1% decline, although at the beginning is not a very big gap, actually it can become a very big gap over time. So, kind of the last slide. we really need to do some idea harvesting, you know, and some of you are probably most of you are too young to remember this, but when I was a child, okay, there was a TV show called Wurzel Gummidge, and it was about this scarecrow, and Wurzel Gummidge had different heads. And he had like a dancing head and a singing head and a serious head. And I actually think we probably wanted to do more idea harvesting than we've been able to do over the last couple of days. But I think you need a different head on to do that compared to, you know, trying to scan things and work them through. So I think that most of this, you know, we should do next. But in terms of the activities that we've been doing over the 2 days, I think that what it's done is it's really validated to us the idea of doing this. I think the other thing that I think is really important about this is staying true to the spirit of Project A, because what always happens, you know, when you work with crowdsourcing platforms and you develop ideas, they move away from the original ideas that were on the platform. It's inevitable. However, I think there are so many great ideas that this is going to be such a good opportunity for us to acknowledge and build on and implement, you know, those great ideas. And just the final thing to say is that the other thing that we did over the 2 days was that we created a wireframe of the potential to actually create this as a web app, and we've even registered the domain. Okay, so we've got our own domain now, and this is the wireframe. So we've got a heck of a lot of work to do, but in terms of all the activities that we've done on this over the last 2 days, I think it's said to us, you know, this is a really really worthwhile thing to do.
Thank you very much, Helen. I think that's absolutely everybody covered. Can I just say well done to everybody. You know, people stepped in, you know, with probably an hour's or so notice. People did slides, people did documents, posters, all sorts of things in terms of feeding back. Your creativity and your ability to communicate across to us in a short space of time is commendable. It really was. So thank you, and thank you all for sitting and listening. Some marvellous ideas. So can we get back to where do we go from here? And I think Helen's going to talk us through where do we go from here.
Yeah. I think everybody's pretty exhausted after these 2 days. So I think the first thing we need to do is, if we can, take a quick breath, you know, and just recover. And then there's a lot of activity, you know, just people have worked so hard, and so much great knowledge has come out of these 2 days. So we need to make sure that we collect and synthesize all the learning, all the all the outputs, and you know, nothing that we've done won't be useful in some way. So then we need to make some decisions collectively about where we take this, because we've got a commitment from Simon Stevens that we can go on doing this for a whole year. So again, it's just, you know, standing back and thinking around what are the things that we should take forward. And you know, I think there are so many great ideas that have come out of these 2 days. What I also wanted to say to everybody who's taken part, like, don't stand back and say, well, we're going to wait and see if he's going to be part of the official scheme or not. Do you know what I mean? If you feel really passionate about the WAST, you know, falls protocols, get on and do it. You know, if there's some quick wins there on that list, get on and do them. You know, like, don't wait to find out. You know, don't lose, I think, the energy of the last 2 days because you're waiting to see what's going to happen officially. You know, if you as a ambulance trust team feel really passionate about the things you do, carry on and do them. So we want to do some reflecting on the experience and outcomes of this innovation burst, because I think what so many of you have said is it's not just about you know, the outputs and the actual practical things that we've come up with. It's about the experience of, you know, working together. It's the fact that there's nearly 100 of us, you know, taking part in this virtual connectivity in an amazing way. So we are going to find a way to bring everybody together again on a Zoom before the 10th of October, and we'll be in touch around best dates for doing that. We need to do a really great communications plan, because we need to think about all the people that came on the 28th of June, you know, the people that made the 31,000 interactions on the on the website and the tweet chats. We need to work with our ACE colleagues to get all the chief execs and chairs and senior leaders on board with what we want to do, and then we want to communicate to the whole workforce. And the most important thing is we want to make some great improvements happen. We want to make a difference to staff, to colleagues, to patients, and we want to help create an environment of connectivity and sharing and experimentation, and that trying things out that don't work is fine, because actually that's the way that we'll take the service forward. So just watch this space, and this is only the beginning.
Thank you, Helen. So do you know what I'm going to do? I'm just going to hold that slide there. So take a quick breath. I just want everybody to read it for a second. Yeah? To make the change happen is the last statement on that slide. Okay? Good. Can we move on then to the final slide? Thank you, Helen, for that. So that's it. The burst is done. Yeah? Thank you massively for all of your contributions, for your commitment that you've given, for your drive, for your energy, for your getting over some of our technical issues, for your products, for your outputs, for your ideas. I could go on and on and on, but I won't, because we're going to finish before 5 o'clock. I want you to do one last thing. I want everybody to grab a piece of paper. It can be a scrap piece of paper. I don't care what it is. I'm going to write on a serviette, for example. Yeah? And I want you to decide, I'm going to give you 30 seconds to do this. I want you to think of the 2 days. What is your commitment going to be to what you have discussed over the last 2 days? It could be anything. It could be small, it could be huge, it could be I'm going to talk to another trust, it could be I'm going to push this idea forward, it could be I'm going to reflect, I'm going to take a breath. I don't really mind, but we need to get some think about each other's and our commitment to each other. So 30 seconds, everybody, write it down. Yeah? So what I now want you to do is I'm going to get Dom now to start recording the GIF. If you remember last night, we all did a huge wave to each other. So we're going to unlock all the lines now so that everybody can hear each other, including if you're on Birmingham New Street Station. We're going to put you all up, right? I want you to show your commitment in front of your camera if you've got one, and I want you to wave goodbye. Are you ready? 1, 2, 3. Goodbye, everybody! Bye, 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 bye. Have you opened up the video sound? Bye. Bye.
See ya.
Thank you, everybody. Take care. Have a good rest of the week. We would like to unmute Helen for a second.
Brilliant work, and this is just the start.
Thank you, Helen.
Thank you, Helen.